According to Statistics Canada, about 15% of all those who contracted COVID-19 experienced lingering symptoms 3+ months and longer after the initial infection. Ontario just introduced a new diagnostic code for long COVID, as it's often known. But as more research emerges from here and around the world, the appropriateness of that term and diagnosis has come into question. Some ask if it does more to obscure than clarify what's going on. With us now for more, in Brooklyn, New York, Dr. Jennifer Frontera, professor of neurology at New York University's Langone Grossman School of Medicine and a member of the World Health Organization Brain Health Neurology and COVID-19 Forum. In our nation's capital, Rewat Danandan, epidemiologist and professor in the Faculty of Health Sciences at the University of Ottawa, and here in our studio, former scientific director of Ontario's COVID-19 Science Advisory Table, Dr. Fahad Razak, who is an internist at St. Michael's Hospital and associate professor at the University of Toronto. And Dr. Razak, we're delighted to have you back here in our studio. Professor Frontera, Rewat Danandan in Ottawa, great to have you two on our program as well. Let me start with just some stats here to get us started here. According to the WHO, the World Health Organization, around 10 to 20% of people infected with COVID-19 may go on to develop symptoms that can be diagnosed as, you've heard this term, long COVID. And a StatsCan survey from this fall suggests some 1.4 million Canadian adults experienced symptoms 3 months after a COVID infection. 1.4 million adults. That's a lot. Okay, Rewat, get us into this here. Many of those 1.4 million have, of course, since recovered from those symptoms, but many undoubtedly have not. How should we understand the impact long COVID is continuing to have today?
Wow, that's a big question. There is a study by an economist out of Harvard that suggests that the economic impact of long COVID on the U.S. system is worth $2.6 trillion, 17% of their GDP. And consider that the actual health output is like 18% of GDP. This is staggering. I don't know what the impact will be in Canada, but it will be of a similar scale. So this is not something to be taken lightly. This could be something that plagues us, no pun intended, for years and decades to come, unless we get a handle on it soon. And that handle will look something like diagnostics, therapies, and preventatives.
Jennifer Frontera, can I get you to weigh in on that as well?
Yeah, I would agree. Back in August, the Brookings Institute put out a estimate that there's about $170 to $230 billion in lost wages amongst working age Americans who are unable to go back to their normal profession because of long COVID symptoms. And we looked at this in a cohort of post-hospitalized New York patients, and even 12 months later, 50% of them were unable to go back to their normal level of work responsibilities. So absolutely, there's a significant impact.
My goodness, Dr. Razak, those numbers are absolutely shocking and staggering. So it obviously behooves you professionals to figure this out at some point. What have you heard about whether or not it's different in the United States from Canada?
Yeah, so the numbers from the United States seem to be probably higher than they are in Canada. And one of the theories behind that is, when did the majority of infections occur? So in Canada, as you know, we had relatively tight constraints on public health measures early in the course of the pandemic, especially before we had vaccines. And it seems to be that if you were infected before you had some immune protection, your chance of developing long COVID went up. So early in the pandemic, over those first 2 years, the United States had more than double the rates of infections that we did. And the prevalence now of long COVID there, based on their national surveys versus our national surveys, is roughly double. So it could potentially explain some of the differences that we're seeing. And it does reinforce why prevention becomes very important when we talk about long COVID. If you can't develop long COVID if you don't get infected in the first place.
I don't want to overly simplify this, but does that suggest that our approach was better than their approach?
I think it's worthwhile now, 3 years out, to ask the question. And I would say that our approach was one of the strictest among G10 nations, for example. But we also had among the lowest infection rates. We had among the lowest death rates. Our research group, for example, did an analysis in the Canadian Medical Association Journal that showed that if we followed countries like the United States or France, we'd have had 9 million more infections in Canada in those first 2 years. 9 million in a population of 38 million, that's a huge number. We'd have had, for example, 70,000 more deaths in those first 2 years of Canadians. So there are very big differences now emerging because of the different policies that were taken.
Jennifer, again, I'm going to ask you to weigh in on the differences between how Canada and the United States approach this issue.
Yeah, I mean, New York is a leader in many things, including the first to have all different kinds of infections and variants, because it is, a big city and a crossroads of the world. So, though we had a little bit of forewarning, certainly we were not prepared for the extent of what we faced back in, March of 2020. I think it was a wake-up call probably for other places, including Canada, of what you don't want to do. And we were really practicing disaster medicine. It's something I hope to never have to do again. I'm a neurointensivist, so I was in the ICU during that time frame and saw how sick these patients were.
I don't want to assume everybody knows what long COVID is. I suspect we all know people who've got it, but let's just get some appropriate definitions on the record here before we continue any further. And again, I'll ask our director, Sheldon Osman, to bring this graphic up because the Centers for Disease Control and Prevention defines long COVID as having, quote, a wide range of symptoms that can last more than 4 weeks or even months after infection. The Government of Canada website echoes the WHO's guidelines and defines it as experiencing, quote, physical or psychological symptoms more than 12 weeks after getting COVID-19. And here's a quote from Zeynep Tufekci, who is a sociologist, occasionally writes in the New York Times, who says the following: current definitions are so broad and imprecise that they impede understanding. Under the CDC definition, someone with a single symptom just 4 weeks after illness can be lumped under the long COVID umbrella with someone bedbound for years. Existing definitions fail to capture the subcategories of long COVID, with different symptom clusters and levels of severity and persistence, creating an obstacle to research and treatments. Okay, Rewa, can I get you to your view of that conundrum that she's identified there in that column?
Yeah, she's not wrong. A broad definition conceals a host of woes. It might be useful to subdivide long COVID into a variety of phases. An integrative model has been proposed, for example, an acute phase, a long phase, a persistent phase. It also conceals the mechanisms. What are the underlying mechanisms here? There's a mechanism having to do with lingering viral presence, a mechanism having to do with tissue damage caused by infection, a mechanism having to do with the inflammation caused by infection itself. And all these things are, again, concealed by this very broad definition. And clinicians tend to approach the treatment of long COVID, to the extent that they are approaching it, syndromically, meaning by clusters of symptoms. And again, this broad definition doesn't allow for the nuanced approach required to dissect that approach. So I think a lot of work has to be done to subdivide definitions better, to better serve the clientele that will emerge as this crisis unfolds.
Jennifer, do you think the definition currently under use is too broad?
Yeah, I mean, I think it was a pragmatic solution when there's no biological markers for what people are experiencing. And certainly the umbrella of long COVID is very heterogeneous. We looked at this in our population, and others have also, to look for clusters or how do these people group together. It seems like, there's a group of folks that have primarily pulmonary issues, group of folks that have primarily neurologic issues, headache, brain fog, et cetera. And then there's a smaller subset of people, at least in our experience, about 15%, that had a lot of symptoms, a median of like 17 different symptoms, with prominent anxiety, depression, and other mood disorder type symptoms. And you can actually cluster these people in terms of how they respond to therapies as well. The good news is that the people that do have a lot of symptoms report a very good response rate when their treatment strategy includes approaches to anxiety, depression, and other mood disorders. I think this just speaks to the fact that we have to have a holistic approach to these folks and not just treat one symptom at a time, but look at the whole context of what these people are dealing with when they come into our post-COVID clinics.
All right, let me follow up on that with you, Fahad, in as much as, can I use this analogy here? We don't really talk about cancer anymore. We talk about liver cancer, brain cancer, lung cancer. Should we be looking at long COVID in the same way? We need to define it more specifically.
I think that's exactly right. And I would say as a clinician who sees patients with long COVID in clinic or in the hospital, our response in medicine a lot of times when we don't understand something clinically, we don't like treating it because we don't understand what's causing it. We don't understand the spectrum of what can present in front of us. And I think long COVID presents us with that kind of problem. It's hard to treat something when you don't even know how to diagnose it properly. And so when you talk about cancer, you don't just treat cancer. You treat a prostate cancer, you treat a breast cancer. And I think long COVID is like that in many ways. You have to think about the symptoms that people are presenting with, try and address those symptoms, even yet as we don't understand that underlying cause. And I think the symptoms can be very, very severe and very hard to treat, and especially in Canada with our constrained healthcare system. This is not an easy blood test. It's not a heart attack where you send someone for an ECG and a blood test and you've made your diagnosis. It is meticulous information gathering. It takes a lot of time. There's a real human interaction element, but we're dealing with a system where in Canada, 5 million people don't have access to regular primary care. So who is going to do that meticulous data gathering to get to the diagnosis? It's a real challenge.
That's a great question. You got an answer for that?
Well, you're seeing that investment now come in, and I think the investment that comes in federally and provincially, for me, the belief is that primary care is the backbone of a well-functioning healthcare system, not just because of long COVID, but long COVID is going to be one of the major draws on the system. If you speak to family doctors now, when patients come in with long COVID, the typical appointment time may be 10 or 15 minutes for a patient. For a long COVID patient, first presenting, that's crazy. You can't get to any part of the history in 10 or 15 minutes. And so our need to reset the system in terms of capacity, the ability to dedicate more time to these assessments, that's part of why this investment is needed now.
I think Dr. Danielle Martin just fell in love with you. That's exactly what she would say.
Close friend and colleague, yeah.
If she were here, she'd say the exact same thing. Ray Watt, the analogy of cancer, do you think it works in this case?
It does, but I prefer the analogy of tobacco. So smokers have a variety of bad outcomes: diabetes, emphysema, lung cancer, cosmetic staining on their teeth. If we were to just approach the symptoms, for the cosmetic staining, you see a dentist; for the emphysema, you see a lung specialist; for the diabetes, you see an endocrinologist. And each of those cases would possibly miss the underlying cause, which is smoking. So I think ultimately we're going to need long COVID clinics in major urban centers that can integrate a variety of specialties to approach these conditions from an interdisciplinary perspective. And I would echo what Dr. Rezac just said about the family doctors struggling with this. What we also need is billing codes, specific billing codes in Ontario for family doctors to be able to apply them and have more time with these individuals who present to them. And those additional billing codes in partnership with the new diagnostic codes will allow us to have a better surveillance on the ground as this nightmare unfolds.
Let me follow up with you on that. We've seen the beginnings of an understanding by the Ontario Health Insurance Plan for billing codes for long COVID. But if I hear you right, you think we're only at the beginning and we need something a lot more detailed. Is that fair?
I think so. I think what a family doctor would tell you is that the nightmare is a diagnosis without a treatment. And we want to make sure that we are linking diagnoses with appropriate treatments, pathways to see the appropriate specialists and so forth, but also assuring that there is sufficient time to see an individual patient, as Dr. Rezac suggested, and a billing code would allow some of that. I think the billing codes for chronic fatigue are appropriate in this case. We can use that model.
Okay, Dr. Frontera, let me try this with you in as much as, let's look at research and treatment. If the whole world right now sort of looks at long COVID as opposed to, in using the cancer analogy, let me take a step back. I'm guessing that when people want to do research projects, medical personnel want to do research projects, they are doing research on brain cancer. They are doing research on prostate cancer. They're not just doing it on cancer willy-nilly. It's got to be more specific. Does referring to this as long COVID impede your efforts to actually make progress on that front?
Yeah, in some ways it certainly does, because if you're not designing a research study appropriately with an outcome that is could be affected mechanistically by whatever your treatment choice is, you risk having a study either with spurious results or a study that's not appropriately powered to show an effect of the treatment modality. So generally speaking, you would have to really focus on, I'm going to look at post-COVID cognitive disorders or post-COVID headache or post-COVID exertional dyspnea, something to that effect. You really have to narrow down the scope of what you're looking at.
I need a translation there. Hang on a sec. I need a translation. You used an expression there that I'm sorry I haven't heard before.
Oh, I'm sorry. Shortness of breath.
Oh, there we go.
Yeah, if you look at patients that have post-COVID shortness of breath, and you say, well, I'm going to lump them with people that have brain fog, and I'm going to study this treatment specific to brain fog. Well, you're not likely to see any effect on the people that don't even have that symptom to begin with. And so you're going to underpower your study, meaning you won't enroll enough people to see the effect that you need to see statistically. So, there is a risk in that regard. There's very few treatments that are going to address all COVID symptoms. One of them is vaccination, however. So there is data showing that if you're vaccinated, you're less likely to have long COVID across a broad spectrum of different symptoms. People are interested in Paxlovid in regards to ameliorating possible viral reservoirs, which might be a unifying mechanism for a variety of different symptoms. We're not close enough to say that that's going to work. So I think in the interim, we have to very carefully define the populations that we want to study.
Let me pick up on that with you, Fahad. Is it likely that there is a single upstream cause that you can target that will help alleviate all the different downstream symptoms that you see?
Yeah, I think there is a single upstream cause, and that is the infection. So this is where prevention becomes critical. So if you don't get infected, you can't develop long COVID. Once you get infected, then the mechanisms start to spread. So for some people, it can be abnormal clotting. For some people, it could be your immune system ramps up and you develop an autoimmune process where it starts to attack your body. For other people, it's scarring of the organs. For other people, it's continued inflammation. So once the initial insult happens, that infection that triggers all of these abnormalities to begin, then you see this spread happen across different processes. And those processes lead to the different symptoms we see. For some people, it's trouble eating, it's gastrointestinal issues. For others, it's racing heartbeats and low blood pressures. For others, it's brain fog. So it's these pathways that spread out afterwards. And that's what makes the treatment at the end of the downstream cascade very difficult. So that's why I think the prevention part of it has to be part of the conversation. And that's why actually I like the name long COVID, because it has the word COVID in it. It mentions the fact that the infection is the precipitant for everything that happens afterwards.
This is interesting, though, because we're 3 years into this thing, more than 3 years into this thing, and we're still talking prevention, which seems so obvious on the face of it, but I don't know what your anecdotal evidence is. Mine is that people have moved on from that.
And look, I get it. All of us want to move on. I can tell you on the front lines in hospitals, I wish this was over after the first 3 months in that first wave. But it hasn't moved on. There is a virus propagating. We had more people die in 2022 in Ontario than in 2020 or in 2021 from COVID. So that was the third year of the pandemic. So it is still here. Now, it is not the same illness it was. We don't have people coming in with COVID pneumonias like we did. But this long tail of the infection causing downstream effects, I think the message still has to be an infection prevented is for the best of all of us. If for you as an individual, the best for society, the best for the healthcare system. And I think we have to talk about what an adaptive response to this looks like now. So as these waves come through, will they flood the hospitals? Maybe not, hopefully not. Could they cause long-term damage? They could. And prevention during the waves, I think, has to be part of the conversation.
I'll pick up on that with Rawat, because as we know and as we've discussed, long COVID can very much affect different parts of the body. Could be pulmonary, could be in the brain, can set off autoimmune issues. Does this mean down the road, when you guys get this sort of more figured out, we're going to need different treatments for different parts of the body that are differently affected by long COVID?
I think that's likely. That's quite likely. Because we're still treating symptoms and not treating cause. And I want to pick up what Dr. Rutz was talking about just now, which is preventing infection in the first place. Thank you. I think we need to have that conversation more commonly. And one of the best ways of doing that is investing in appropriate public health infrastructure like clean air, strategic masking, but also new mucosal vaccines, which we've sort of lost our eye on lately. mRNA vaccines sort of take up all the space. But there are a flotilla of new mucosal vaccines being trialed, and I hope that we have the wherewithal and the enthusiasm to adopt them in this country when they become available. They'll be able to prevent infection and transmission, we hope. But to answer your question, it is likely that we're looking at an entire set of new therapies that are going to have to evolve. What they look like, I don't know. But what I'm hoping is that we make the investments in the research platforms to allow us to develop them.
Now, I picked on Dr. Frontera a moment ago for saying something I didn't understand because it didn't sound English to me, so I'm going to pick on you now, Rawat. You used an adjective in describing a vaccine there that, again, I have not. What was that word?
Mucosal. So intranasal vaccine, for example, a vaccine that elicits an immune response in the mucosa where you first encounter the virus. If you think of it as a bouncer at a nightclub, you'd rather have the bouncer keep the troublemaker out of the nightclub rather than have to evict them once they're inside. So a mucosal vaccine could keep infection from entering your body in the first place. So a lot of work is being done on developing intranasal vaccines. India has one, for example. We don't know yet if it prevents infection and transmission, but we don't talk about that enough in mainstream media. A lot of work is being done behind the scenes on it. And I'm hoping that the enthusiasm will be rekindled to develop them further.
Gotcha. All right, let's move on and talk about those who are actually struggling with long COVID today and what sort of treatment options they have to ameliorate their situation. Jennifer Frontera, you want to get us started? What do you recommend?
Yeah, so I can say I'm working with a working group from the WHO, and we're putting together some kind of consensus on therapeutics, at least for post-COVID neurological symptoms. Because there's, if you look, there's very little clinical trial data that's currently available for any symptom that you might imagine. So, in the interim, while people are trying to figure out both the mechanism and possible therapeutic approaches, we are sort of left applying our best practices depending on what you're looking at. So you might follow headache guidelines if you're dealing with post-COVID headache, et cetera. And so I think that's the best we have at the moment. And understanding it's very frustrating for those who are suffering with long COVID because it's been 3 years, but it's just difficult to develop specific targeted therapies when you don't really have a handle on the mechanism yet. And so science is slower than we would like it to be. I think one risk that you alluded to is there's people want to move on. Funding mechanisms, at least in the US, are expiring. So the money available to delve into this more is starting to dry up. So, I hope that the voices of people suffering from long COVID can be heard and that we can continue important work to try to identify targets and treatments.
Fahad, what are you seeing in terms of accessibility to, for example, Paxlovid here in the province of Ontario for those for whom it could do some good?
Yeah, I think access to care in general right now in Ontario, and this is Canada-wide, this is not blaming Ontario, for patients with long COVID is very, very poor. So people are waiting 6 to 12 months at least now to get into some of our specialist clinics. There's very few of them. People are desperate. Every time I do, a show like yours, I do an interview, I get back to my office and there's voicemails waiting for me from patients who are desperate to see somebody. Please help me. I haven't been able to get an appointment. It's very, very difficult. And we know that these specialist clinics will not be able to provide the bulk of care that's required. So what we need is a pathway. We need clear guidance for primary care.
Guidance from whom?
Guidance from the government, from the Ministry for Ontario, across the provinces and territories, federally as well. What can you do as a family doctor? How do you do that first round of assessment? Are there enough family doctors? We talked about this earlier. And then for the people who needed that referral into the specialist care networks. So there's not going to be enough specialists for everyone, but even for now, the primary care doctor who is seeing this patient, there's not clear guidance for them, and that's really needed. Here are the tests that you do, here's how you interpret the results, here's when you refer. That's not clearly mapped out right now. The other thing I'll say is for research, so Dr. Frontera mentioned the United States. Their investment for long COVID research eclipses what's happened in Canada proportionally. I know we're a smaller country. So they've invested over $1 billion in the United States in long COVID related research. In Canada, per capita, that would mean we should have invested about $100 to $200 million at this point. We're nowhere close. It's a fraction of that. So there is a real opportunity, I think, to catch up on the clinical gaps that exist, providing that frontline care, but also the research in the background that's going to help us develop the next rounds of treatments, the diagnosis, all of the things that we need here to care for this.
Just before I get Rawat on that, what do you do when you go back to the office and you clear your voicemail and you hear all these very sad stories? What do you do?
I mean, there's not a lot I can do. So I call back whoever I can, or I email back whoever I can, and I say, here's the clinics that I know of that are in Ontario, but there is a long wait list. We're talking about 6 to 12 months. If you are a parent who is having trouble keeping your job because of long COVID, or having trouble caring for your kids, if you're a student who's having trouble going to school after developing long COVID, 6 to 12 months is a lifetime to wait in order to get that treatment in place. And remember, the treatments are not miracle treatments. We're talking about symptom control to the best of our ability and often highly, highly imperfect. So there is not a great solution when you hear these stories right now. They're heartbreaking, but there is not a great solution.
Ray-Watt, in your judgment, what do we need to do to make some progress on treatment?
Well, this is a public policy show, so let's focus on what we could do in terms of public policy. We could fund research, absolutely. We could create better billing codes, absolutely. We could create dedicated endowed research chairs. We could increase vaccine uptake. So vaccination reduces the risk of long COVID by about 15%, according to some studies. And with each additional booster, it may even be better. So booster uptake in this country is quite poor. We could increase that. We can make eligibility for the bivalent vaccines wider and reduce the likelihood of becoming infected in the first place. We look into mucosal vaccines as well. We can develop long COVID clinics in urban centers so that we have the interdisciplinary expertise waiting for individuals to not just get their one or two symptoms treated, but get the host of all their underlying conditions addressed as well. We can develop clinical guidelines for family doctors and other specialists to assist them in how to, again, deal with these patients presenting anew with a host of new issues. So a lot of work needs to be done. Government has to take the lead on this, both provincially and federally, and has to do so in partnership with the various medical colleges.
Let me do a quick follow-up with you on that, just on one thing that was on that list, long COVID clinics. If, for example, the Minister of Health decided today that she wanted to create new long COVID clinics, how long would they take to set up?
Oh, I have no idea. One could do a quick one inside a hospital in a matter of a couple of weeks, pro tem, but a permanent sort of system, possibly months. But I pull those numbers out of various ethereal orifices, so do not take them to the bank.
Okay, I know we don't like too many fancy words on this show, but even I understood what you meant by that one. Very good. Okay, how about in the United, I mean, we just heard a second ago, Jennifer, that the United States has really made a commitment to studying long COVID in ways that are disproportionate beyond the size of our respective populations compared to Canada. When do you think you will be able to get a handle on this issue as it relates to American patients who are suffering from it?
Yeah. So the Recover initiative, which is, I think you referenced to some extent, is the $1.15 billion appropriation from Congress to study long COVID. That's a multi-pronged study across different age groups, children, adults, autopsy studies, electronic health record studies, et cetera. And that's been going exceptionally well. And I think, at least in the adult cohort, for example, there's like 15,000 people that have been enrolled. It's a longitudinal study. I think it's going to be ripe for actually harvesting and that data and publishing it in relatively short time frame. So I think that's going to be substantially helpful. There's also mechanistic components to that grant. And the NIH is also sponsoring a clinical trial, which will be Paxlovid, for long COVID. And so that's on its way to being up and running. So I think, things take longer than we would like, but we're making good progress towards at least exploring different therapeutics and mechanisms in the U.S.
Fahad, are you hearing stories in your circumstances where people are essentially putting together their own, people are on the internet and they're doing their own diagnosis and they're coming up with their own treatment plans now? You seeing much of that out there?
Yeah, hearing about it for sure. And look, I don't blame people. So there are not well-established treatments for this condition right now. Of course, I would say as a clinician, be safe, speak to your family doctor if you have access to one, or your clinician. Do things that at least can be monitored and people make sure that what you're using is a safe product, and trying to get a sense of, with logs of symptoms, whether you're seeing some improvement over time. But look, in a vacuum, people will do desperate things. And there is clearly a vacuum right now in terms of available resources relative to the demand that's in the Canadian population and here in Ontario. And in those circumstances, you see this happen. We've seen this happen in medicine before when people don't have access to care. So I understand why people are doing it. I'm hopeful, as Dr. Frontera mentioned, that some of these trials that are looking at Paxlovid or other medications will start to show benefit, but it's going to be a slow, painstaking process. And right now, the best we can do is to match every patient who has need to a clinician who can do the long, slow work of monitoring symptoms and trying to get a sense of what's working and not working.
I'm going to toss you a softball question here. What's the status of the science advisory table for COVID-19 for the province of Ontario?
There is no science advisory table.
Exactly. So I mean, who needs to get this message in order to have things happen?
Look, we do have a strong clinical infrastructure in this province, and so I value the time of what we did in the science table. I hope it helped, but there are structures in place. So, I don't want to pretend that there's not structures in place. Public Health Ontario, the Ministry of Health, Ontario Health, there are structures. Now, look, the challenge with long COVID is that it spreads its fingers over multiple areas. So it is a challenge for primary care. It's a challenge for acute-based care. It has multiple areas that it's going to draw on the system. One of the things that Zeynep Tufekci said in her long piece in the New York Times is that recognizing that cancer, as an example, required the pulling together of the system in many ways. They developed the National Cancer Institute in the United States. Do we need a parallel kind of body that's looking at post-viral syndromes or post-infectious syndromes in general, of which we care a lot about long COVID right now, but obviously there's many precedents in healthcare, in human health, where infections acutely, then downstream, lead to all of these other side effects. So do we need something to pull all of those threads together into one institute that will connect all of these parts of the system?
That is a great question, and since we have a minute left, I'm going to give it to Ray Watt to give the answer to. What do you think?
Yeah, specifically, we need an institute for long COVID, but a post-viral syndrome institute is not a bad thing. In addition, I think we need to reinvest in medical school education. We don't really teach a lot of post-viral issues in medical schools. So I think we're looking at a reimagining of how clinical care will have to evolve in the coming years.
If anybody from Public Health Ontario or Ontario Health or the Ministry of Health or any of the other numerous institutions that are sort of keeping an eye on this story, if any of them watch this show, you three have given them all a great to-do list of where to go going forward. Are you hopeful that something's actually going to happen here?
I am hopeful, cautiously hopeful. Will it meet the scale of what's needed? I'm not sure. Has it started? There are investments federally that are in the works that will be announced, I think, in the coming weeks to months around investments on the research side. We've heard from the ministry in Ontario and across the provinces and territories that there are investments coming on the clinical side. Now, the details matter here. So what is the gap relative to the people who need care and the resources available? Where do we fit Canada in the research enterprise globally that's happening? Those are the important details that I think we have to answer, but I am cautiously hopeful.
Jennifer Frontera, Ray-Watt Dan Anden, Fahad Razak, thank you all so much for being on TVO tonight. We're grateful for your time.
Thank you.
Thank you.
Thank you.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.